what I'm presenting today is not clinic data, but more community data. I think we heard just anyone who was privileged to listen to Suvarna Patil yesterday, that was a lot of community work and similar stuff what we do in the community. So when ma'am gave me this topic of reversal of diabetes, translational research outcomes, our department was then named translational research, but we had to change it properly to Department of Preventive and Digital Health Research, because a lot of people thought translating means to translate languages. So nobody really understood what translation research is, so we had to kind of make it simpler and say what exactly we are doing. But what we do is field studies, large-scale prevention in the community. So you take the research, if you talk about translation research, there are T1, T2, T3, T4, there are work that you can look at, and it happens in the lab. It starts with animal models, then it goes to small-scale people, and then once it's established in the clinic, it's then that research in the end has to go to the public, right? What is the point of it remaining in the clinic? So if you want to prevent, there's only so much prevention that can happen in the clinic. If you really want to prevent something, you have to go to the public at large, and that's why translation research becomes important. Going back to this, I've been saying it again and again, this I think is the only conference I have attended on pre-diabetes, at least in my last 18 years of working in this field. And but I would still say I come just for Subhadra ma'am. And Dr. Anuradha Mitra, and a lot of my teachers here who were my gurus when I was studying in Nirmala. And thank you ma'am for this invite, and thank you for introducing us to Mr. Gopal Sharma, and thanks Neha, Sudha, all for all your coordination. So let's start now. And we've been seeing, Sir spoke a lot of biochemistry, and there was a talk full-fledged on nutrition before that. I'll just take you a little back on prevention, since that's what we're speaking about. Does this work? Yeah? Okay. So, I have given a different list of stages. So when yesterday Dr. Mohan spoke, he spoke a little bit about primordial and primary. So what can we do at every stage of prevention? So at primordial, what we're seeing is in the family that there is just risk factors may not be there, but you're kind of spreading an awareness at that much earlier stage before even risk factors might set in. Then you have pre-diabetes stage where the actual prevention, where your it's like a captive audience sitting there. You can really attack them, and then you can at least prevent this diabetes. And again, I will come back to the word prevention, of so many years of working also again in this field. I would say more than prevention, what you do is delay the inevitable, right? And why it is important, I'll tell you, I don't want to discourage, it's not like, prevention to hota nahi. It's not like that. What I'm trying to say here is, we do enough epidemiology studies and see the age of onset is much younger in the South Asians. So we see people with diabetes and obesity at the age of 25 and 30, the takeoff age. Whereas when you go to the Western Caucasian population, it's 45 and 50. So it's basically 40 plus. So the complications that happens after 10-15 years for a person who gets at 45, imagine that at a person who's getting at 25. You're getting it at the most productive stage of your life, when you are going to be stressed. You'll be earning, you might be married, you will have children. So you have enough stress in your life anyway. All this is part of life. It's nothing new that you're doing. But at that point of time, if you're going to have diabetes, there will be complications that will start because you're not really looking at your health, though you need to, but these are the facts of life. So the idea of prevention now has slowly moved to delaying that onset of diabetes to a much later stage in life. And as Dr. Mohan again very rightly pointed out, even if a person gets diabetes, it is not the end of the world. There are fab medications, and believe me, I'm a prevention proponent. So if I'm saying there is so much good medication that's available also, which will support you in your lifestyle therapy. So it is not the end of the world. The idea is to prevent complications later on in life. So that should be your mantra for prevention. Yes, prevent it, great if you can. But when we talk about remission and reversal, I'll tell you what is the issues there and how we can merge this. My idea of my talk today is that's why I heard everyone's talk, and then I kind of made it again today to see how you can get prevention and remission on the same page. So we already spoke about, just putting the statistics out there again, 101 million people with diabetes and 136 million with pre-diabetes. Let's be clear, it's like a country of its own, the people with pre-diabetes, okay, or more than 2 countries of its own. So if you want to prevent on that, it's not happening, okay, let's be practical. So what you have to do is focus, who are prevent, and what kind of prevention that you're going to get on all of them. So there has to be a very captive audience sitting there who are listening to you. So they have to have a structure. So there is, we have touched upon mental health and things like that. It's this remission or prevention is not for everybody. You have to have somebody who's there focused, and you have to be that focused, Addressing it in a group, it's not going to happen. So there has to be very niche things that we have to be doing here. So is diabetes reversible? Okay, coming straight to the point. So type 2 diabetes is a chronic disease. You understand the difference between acute and chronic? Yeah? Can somebody tell me the difference between acute and chronic? What is acute? Short term or onset is sudden and it will go off also in some time. A viral fever is something that can be acute. Diabetes is not acute, it's chronic. It's a progressive disorder. It will keep on going, and it's a very silent disease. So nobody will, report saying they died of diabetes, no? Anyone, you've never seen any postmortem or anything. They'll die of a heart attack, they'll die of something else. But that diabetes is always lying there, that hyperglycemia. And that's why it's progressive. And as years pass, if it's uncontrollable, you will need medication, the person will need insulin. And from what our studies again are showing in the clinic, 50% of individuals over 10-15 years, and this I'm talking about uncontrollable diabetes, will require also insulin therapy. But this deterioration and this control and the idea that it has to be treated also makes it not curable. Do we have a treatment? Do we have a cure for diabetes? We don't. Okay, we don't. So what we are trying to say is, then can we reverse it? Can we really remiss it? So let's understand first what is reversible diabetes. I said that going back to the natural history, you can do it at different stages, right? What I'll be talking on today mainly in the conditions that you can actually reverse diabetes is pre-diabetes. I'm focusing mainly on that, okay? Because the other things I'm not going to talk. I think yesterday evening session, Shilpa Joshi and Dr. Neeta Deshpande spoke about diets and reversal based on the counterpoint and all the different studies that are there. There's a lot of work that's happening on remission, on reversal, which is related to food. But I'm talking about pre-diabetes specifically in the community and how through lifestyle modification this can be done. Please remember, reversible and these terms cannot be used for type 1 at all. Let's not even try there. Okay, we have different type of diabetes, don't get mixed up. Type 2 diabetes, the garden variety type 2 diabetes is what we call it, is where we can try these things on focus on a few people. Now, very, very important. I've been waiting for someone to speak about this, but I don't think anyone has touched about this since yesterday. There are two words here which we keep using, reversal, remission. Okay? So the term reversal implies that the condition has been completely cured. We just said diabetes cannot be cured. So can it be reversed? No. Okay? What you do is remission. And where does the term remission, I think Luke keeps speaking about, but the word, it comes from cancer, right? So this whole thing of remission has come from the cancer pathophysiology and things like that, which says it is there somewhere inside, but it's not coming out. So it's there, you just kept it, below somewhere, which means it's a kind of prevention. That's why remission and prevention go hand in hand. But reversible is honestly a wrong term, because for a disease which has no cure, how can you say it can be reversed, right? It can only be short term. You're reversing it for a short term. You're going to come back. So let's not fool our patients and say it's called let's call it what it is, and it's called a remission. So there are several studies in terms of prevention of diabetes, and going back, so there is Dept from US. I really urge you all to look up these papers. Anyone who's interested in going on to do scientific research, even in the clinic, you need to know what these data tells you. So there's Dept, which is the Diabetes Prevention Program from the US. Then there's a Finnish Diabetes Prevention Program, that's Finland. Then you have Dacheng from China. You had IDPP, which was done by Dr. Ramchandran's group initially in India, and then we came up with Dept. And the difference between IDPP, I get this a lot, is what is, that's also prevention, yours was also prevention. They did not do a structured lifestyle lesson. What we did is we actually took the DPP lesson plans, made the 16 classes lesson plan structure, and actually implemented it in the community. So these are the Dept investigators. This was funded by the IDF grant, by the Bridges. They had a grant called Bridges for Translational Research Outcomes. And these are my collaborators, Lisa and Melba. Actually, this was one of the first studies where foreigners got their PhD in this study. So we go abroad to do PhD and get from there. They both came here, helped me run the study here, and got a PhD out of it from MD University. So this was our recruitment. And I'm going to talk a little bit about the study for you to understand how challenging it is to do remission, prevention in the community. How many numbers you need? In the clinic, you're getting an audience coming to you. So it's a different task altogether. But when you have to go to the community to do it, it's a very different task altogether. So what we did is we screened around 20,000 people around Chennai, okay, to finally randomize 600 people. How did we do that? So we went and targeted overweight people. Obviously, you would target a high-risk group. And from there, first we do an RCBG and we have the IDRS score. From there, we came down to around 1 to, look at the numbers, from 19,937 we came straight to 1,285, then we came to do OGTT. Lot of people would think it's NGT, lot of people move from pre-diabetes to diabetes very quickly. To get people from an RCBG stage to an OGTT also, it takes time. You have to call them, you have to come to you, it's a 2-hour OGTT. You wouldn't believe that within a month's time, there were people rapidly transitioning to diabetes too. So we were losing people there. Then of course we randomized the 600 and they get randomized to the 2 groups. Now, looking at the recruitment, how did we get these people? Where do we get these people? And I put this up mainly for you guys to understand when you do these camps in the community, how do you go and get these people running? So you have residential apartments, you had corporate offices, we had schools and colleges the teachers. So what we used to do is go give a talk on prevention of diabetes, and then we used to do the screening on them, and then we used to tell them about the study, and then ask them to join it. And then we had camps in worship places. In India, we have a lot of places of worship. It's a good place to target a captive audience, and especially if you have the priest or somebody in, they're the best people, honestly, as community, more than community health workers, to impart that message. And we did have priests, and we did have, whether it's in the temple or in the church or in the mosque, give out these messages out to the people on prevention, and that actually helped a little better in getting people into the study and then keeping them there for the next 2-3 years. And also general awareness messages. They're a good audience, they're a good leader. You need community leaders to take programs such forward, and they are good people to give out those messages. So let's look at how this funneled down. Okay, so when you do targeted community screenings, based on the high risk, we had 20,000 as I said. From there, eligible for OGTT were around 18.2%, and finally, the ones who came for OGTT were around 3.94%, and we randomized around 2% from there. Whereas when you take referrals, and that's why I say in the clinic, you get a captive audience, you will get people coming to you, and they are the best people for you to immediately start your work on. If you start from a referred to a baseline testing, for every 5 people referred, literally 2 people were getting randomized. Whereas for every 55 people referred, in that community that we screened, only 1 person was finally eligible and consented to randomize. So what was our lifestyle intervention? So now with this, we had our 650 people in our study. We had 16 lesson plans which followed DPP follows a trans-theoretical model of behavior change, and we had 16 lesson plans, each speaking on fat, carbohydrate, protein, exercise, and we had 45 minutes of nutrition education being given one-to-one to a group, and we had 45 minutes, almost 40 minutes of exercise also being done, and these were our goals. So I said, it's similar to DPP, we just adapted the lesson plans to the Indian setting. And after what we added as a step up to the DPP had a separate metformin arm. What we didn't have a separate metformin arm, we added it as a step up that after 4 months, if blood sugars were high, which means they were still in the pre-diabetes range, that is they were 5.7, they were in that 5.5 to 5.7, little high range, then we would put them on metformin 500 mg. We then also enrolled a lot of lay interventionists, we call them diabetes ambassadors, who were people with diabetes, okay, but felt that if they could be part of such a program, they would have prevented diabetes or they could have controlled their diabetes better. So since we were associated to a clinic, we had a lot of these long-standing patients who were more than happy to come and give their gyan, and come and give them, share their experience. So we put them as part of each of these groups, and they would come and mentor that group. They would come and say, look, I did these mistakes and I hope you all can understand. They would join the exercise. We even made them take some classes. So these classes, as I said, it's not like I'm talking, you're all sitting, no. They were interactive, there was role playing, there was a lot of, that's how the DPP lesson plans are structured. If anyone can look at it, they're freely available, you can just go look it up. It's a very nice lesson plan, a nice guide to help in the prevention of diabetes. So they became our diabetes ambassadors, who basically role model for others. Now just a few perspectives, quantitative data everyone shows. Since I do a lot of translation and implementation science, I think what we really need to do if you're doing lifestyle intervention is qualitative research. You need to, and qualitative research is not just going and taking one interviewer, that is not qualitative research. You need to get trained on how you do qualitative research also. Because it's very easy, na? You can go and say, so you like my program, na? You're already telling them you like my program. That's not proper. So that's already bias over there. There's a way of conducting an FGD, a focus group discussion, a key informant interview. But if you're doing lifestyle classes, it's very, very important that you get qualitative perspectives of the participant, right? So if you see, from the Dept point of view, participants' improvement in health and quality of life. So you get domains, you get themes, and then you categorize them by them. So they are saying they told me to do exercise and follow diet restriction and told me my weight was 88 kg. Now I controlled it and it's come. And Dept program was 16 weeks, which is meaning 4 months. Weight reduction is there, my energy levels are increased. I feel confident, active, energetic. When we came here, we did not have the interest, but now after seeing everybody, we are motivated. Earlier we used to have food without limit. Sorry. So there was something on portion control, 2 chapters on portion control, and that's how they learned about how much they can eat and when they should stop. So, when people join such programs, and why I'm saying this again, prevention, whether it's a prevention or it's a remission, reversal program. I'm saying reversal again because that's what people call it. Let's just stick to remission. If they join, also they want to join, make a plan such a program, initially there will always be reluctance. You need a lot of convincing power. You need to believe in your program that it works first, or even you'll be able to convince. So whether you're giving a diet plan or a nutrition plan for your patient, you need to believe that it works. If you're just giving something that's ready-made and just handing it over, then that patient is anyway not going to follow. So that's where I'm coming from. Whether it's a program or whether it's a prescription, it's all the same. So as they say, in the initial no one expected, they just came for the heck of it. But after 6 months, they understood, when they seen the changes that happened in their lives, that's when they realized how beneficial this is. So with that, sir showed the slide on how we got, but I thought it's important to tell you how we got these results. People just put the paper up and then it's like, okay, we got these results. But there was a lot of work that went through the 3 years for us to come up with this. And we got a 32% risk reduction overall from Dept. But as Dr. Mohan also pointed out yesterday, there was a lesser risk reduction in the IFG compared to IGT. But I'd like to now point out in my last few slides about how the other end of the spectrum. Okay? So in the conclusion, we did say that maybe the prevention messages need to focus a bit and we need to do something more maybe for IFG because that's what we found. We found it easy for IGT that, since it's more driven by insulin resistance, people lost weight and hence they easily prevented diabetes. Now this is unpublished data, so I would request you not to take any photograph simply because this is being written up for publication. This is a regression paper, okay? Now when you see this, now we are look at it as a base model and then you're looking at adjusted for weight and adjusted for waist. When you look at these points, whether it's IFG, IGT, IFG plus IGT, everywhere there have shown regression to normoglycemia. So they may not, many people from IFG maybe ended up with diabetes, but there were enough numbers who also regressed to normoglycemia. And when you say regression, your definition of regression is also very, very important. People keep saying regression. What is regression? One time you became, my diabetes levels was 250, today I'm 105. So, or that's still pre-diabetes, or I'm 95. Have I regressed? Is that it? There has to be some time, there has to be a duration for how long you regress. And during that, so for us, our definition of regression was during the duration of study. There were people who regressed once, okay, that is they came back to normoglycemia and then they went back to pre-diabetes. They did not go back to diabetes. But there were people who regressed and stayed there throughout the study. So we call them true regressors. So we were looking at only those people who regressed and did not even move back to pre-diabetes. Those were our numbers. And when you look at them across the spectrum or stratify them across the diabetes categories, you realize that even the regression, if you look at the Dept work, even in the IFG. So where are we going? So we are saying these IFG people need a more focused intervention. Maybe there is something with diet that can work better on them. But when you look at if you're going to look at remission, they seem to have also worked there. The IIG people seem to be remissing back to normoglycemia. So there is some underlying factors being played here, and also weight definitely played an important role both ways. So lower weight, even when we look at factors regressing to normoglycemia, people with lower weight regressed and stayed there, no doubt about it, and that's not rocket science, it's understood. But at the same time, because your insulin resistance is gone, automatically insulin sensitivity will increase. But a long-term attack on those pancreas, where the insulin sensitivity slowly starts losing out, that is the issue. Those are the people who are going to be very difficult to regress. And my last slide, actually my last two slides here, is I want to focus on this. I looked at it based on attendance to classes. I said there were 16 classes that they attended in Dept. Now, if you see the regression based on attendance to classes, the more number of classes they attended, the more was the regression to normoglycemia, right? So, and look at it is abnormal. I mean, it says 26 and all that. That could also be a figment of the number. Number of people in IIT were lesser. But just the fact, look at 1 to 7 classes. 1 to 7 we kept as reference. 8 to 12 classes, and then 10 to 16 classes. Okay, so from there, from the 12 to 16 classes and 8 to 12, look at the progression. So people, more classes they attended. What that slide is telling you is the more number of classes, education classes they attended, more they were able to regress to normoglycemia. And I think that's a very important take-home point, because from there, mainly your take-home message should be is, there are a lot of people, okay? There are a lot of companies promising reversal. So, as a dietitian, as people, taking home and spreading to others, you need to first understand whether it's remission or reversal. It's not reversal, it's remission, right? And you need to advise your people. I'm sure all our public is more smarter than us, right? They all come with a Google thing, telling you what needs to be done with them. So you need to be, as a scientist, even as a dietitian, you can be a scientist if you're well read, and tell them that information back, saying this is not reversal, this is remission, and if you do this, it will last you for so much time. If you do this, it's going to be more sustainable and it's going to last you a long time. So remission possible, reversal, as I said, is a question mark. Till you have a cure for diabetes, I don't think you can be saying reversal for diabetes. And what I think we have been discussing since yesterday is sustainable lifestyle changes. And just my last slide from our paper on regression to normoglycemia is, the more sustainable, the more continuous your education with your patient is, with your participant, whether it's a study, the more longer time you go on, that is, you just need to be in touch with them. And I think that's why your digital tools can really help. I know most of my dietitian friends use WhatsApp, to be in touch with their participants and ask them to share their food rate. And if you just take even a general survey, how many of you use WhatsApp? Many of my professional dietitian friends use WhatsApp. Do you think you've got a better compliance based on that? That's the most basic that you don't even need an app. Just have a basic digital tool, and this has just been enough because you're getting feedback. They feel that you care. Okay, it might be some robots who sending it, doesn't mind. But they feel somebody's talking to them, asking them about their health. Today I tell you, we don't even have time to ask each other how are you, right? And I find it very strange in India. I'm sorry, I'm going away from detracting from the topic. We don't say hi, hello. What do we say when we first meet people? Oh, you've lost weight, you've gained weight. That is the way we address people. So that's how it is in India. So there's no hi, hello, what's happening in your life. So from there, when you want to move on, when you have a WhatsApp buddy asking you, well, do you have you eaten, how much have you eaten, and what have you eaten, okay, great, you've lost so much weight, or you're good on, it's okay. Those kind of encouraging tools will really help sustainable lifestyle changes. Thank you.